A very special presentation because we have Dr. Huayan Zhang from Children's Hospital Philadelphia and Guangzhou Women's and Children's Medical Center. And as you all know, she is our BPD god. And she will be talking about a very common problem we have here. Oh my goodness. We are not having a good time with sound. Okay. Someone keeps unmuting themselves, about when do we turn our babies over to BPD ventilation modes. And she will also launch a new initiative of ours in this region, the Asian Pacific BPD Collaborative. So Huayan, I think I need to monitor the people who are unmuting themselves, so I'll pass the baton over to you. Thank you very much. The floor is yours.
Great, thank you. Thank you, Julie, for your invitation and also introduction. So today, the talk that Julie gave me was can I flip my baby over to the BPD ventilation? I don't know what do you guys have in mind, but I'll share with you guys what I think. Well, first of all, I have no conflict of interest to report, and we will not discuss any commercial product today. Now, before I start, I would like to talk about our BPD Collaborative Asian Pacific Network first, because this is our new initiative that we just formed not long ago, and this is part of the big BPD collaborative. The goal of the BPD collaborative is to improve BPD care through international collaborations. I just came back from Philadelphia. We had this the 12th annual Children's Hospital Philadelphia BPD conference, and also in conjunction with the BPD Collaborative annual meeting last week in Philadelphia. It was a 3-day, very productive meeting, sharing knowledge and interactions about BPD care. So the collaborative goal is to, through sharing the data and also QI initiatives and research proposals, we can foster interdisciplinary collaboration and innovation in the identification and treatment of these very, very vulnerable patients. And last week we heard from two parents about the journey of their baby. It was really, really moving. And I'm sure all of you have taken care of babies with BPD, especially very severe BPD, and their journey were not very easy. Now, the BPD Collaborative, right now there are 54 U.S. centers and also several international centers from Japan, Sweden, British Columbia, Italy, Germany, Holland, and Belgium. And then we just form under the big umbrella of the BPD Collaborative, we form the Asian Pacific BPD Network. So here are the list of current members centers. We talked about starting small. So currently there are 14 centers from Australia, Chinese mainland, Taiwan, Hong Kong, Japan, South Korea, and Singapore. All right, so we, with this Asian Pacific BPD network, we're gonna start with education series. So this is our first lecture of our lecture series, and today we'll talk about the BPD ventilation. And hopefully by the end of this talk, people can identify the changes in pathophysiology and lung mechanics from RDS to BPD, and also understand our rationale of key ventilatory support strategy for infants with established BPD. Okay, my typo is when to flip to BPD ventilation. But what is BPD ventilation? So my interpretation is that this is to use mechanical ventilation and support the baby with BPD. Now, is it one specific way to support? or multiple ways of support? I think before we answer that question, we need to go back and ask this question first. Do all BPD babies have the same lung disease? These are some pictures I downloaded from Google. Okay, apparently these are 3 different babies with BPD, and they have all considered have severe BPD. Now, do their lung disease are the same? Let's look at some examples of the babies I have taken care of. These are 2 babies presented at 42 weeks post-menstrual age. The first baby was born at 30 weeks, but the mom had ruptured membrane at 23 weeks. The baby initially was on non-invasive support until 8 weeks of age, and then intubated for worsening work of breathing. But then since that time, it was very difficult to wean. And that's the chest X-ray, the baby, at the time the baby came to CHOP. And then the second baby was an 25-weeker, had early onset of sepsis, and then was intubated and mechanically ventilated since birth. The baby had 4 weeks of high-frequency oscillation ventilation and then changed to conventional ventilation. Baby also had a history of pneumo, was on 100% oxygen for a period of time initially. And you can see that's the chest X-ray when we saw the baby. Now, for these 2 babies, do you think these babies' lung disease are the same? This baby, if you do lung biopsy, the first baby you would see basically very simplified alveolization. It's a delayed development of the lung. But the second baby would be more like this old type of BPD with areas of delayed alveoli development, but also areas of fibrosis and significant injury, right? But both of these babies, per our definition, have severe BPD. Now, for the BPD babies, when they're first born, most of them have pretty severe RDS, or some of them have mild RDS, right? But either way, they are born with very immature lungs, usually in the saccular or canalicular phase. And then over the course of several weeks to months of their care in our NICU, they go through lung development. But at the same time, whatever they are experiencing, either the mechanical ventilation we're trying to support them with, the high oxygen or infection, they may come up with lung injury. Once the injury happens, they need to repair their injury. So this process of lung development, injury, and re-injury repair is an ongoing process during their time in our NICU. And by the time they get to the time that we can diagnose them with BPD, they end up with different pathophysiology. And when we look at these babies, this is a paper we published in Blue Journal back in 2020. When we look at these babies all labeled with severe lung disease, severe BPD, those are 76 babies born at less than 32 weeks with severe BPD. And we looked at how they're present to us, right? And when we found that some babies have their BPD, really the predominant feature is the really severe lung disease. But there are other babies also with lung disease, may not be that severe, but they have significant airway disease, or they have severe pulmonary vascular disease. I just finished 2 weeks of service over at CHOP on the BPD team. Out of my, I think this time I only had 14 babies on the team. There were 4 babies with pulmonary vascular disease, not the traditional ones that we talk about, pulmonary hypertension. I actually have 4 babies with pulmonary vein stenosis. Okay, so these babies have lung disease, but they're predominant feature is actually pulmonary vascular disease. So when we talk about severe BPD case, they present with different phenotypes. And I thought this paper kind of, this picture really represent the mechanism and also the phenotype of our BPD pretty nicely. So in our paper back in 2020, we talked about severe lung parenchyma disease, pulmonary vascular disease, and airway disease. But at the time when we investigate airway disease, we focus on large airway. However, clinically, honestly, I'm really afraid of those babies with small airway disease because they're very, very hard to handle. So the airway disease kids may have large airway. Babies that I have taken care of over the years I've been working at CHOP. The third baby here, baby 3, present to us in pulmonary hypertension crisis. Both baby came with PH crisis. The first baby was born at 23 weeks and was mechanically ventilated for 2 months. And then over the course got 3 courses of steroids, transferred to us at 46 weeks post-menstrual age for PH crisis. And you can see that admission trajectory. It's a huge heart, right? The fourth baby was born at 28 weeks, had one prolonged course of steroid of 23 days, but was actually never intubated from birth, was on non-invasive support. And then actually his support was as low as 1 liter per minute at some point. However, he was then progressively worse and needed to be intubated. And this is his actually when he came to us. Now, they're both severe BPD with pulmonary hypertension crisis. Do you think these 2 babies would be the same? In reality, when we really worked up these 2 babies, they both required pretty high PEEP to really get them better. So both of them are PEEP around 14, but they really have different reasons. The first baby, the baby 3, we found has significant airway disease. So you can see on the CT scan, he does have lung disease, but it's not terrible. However, when we look with bronchoscopy, we can see this baby's airway really collapse when when you don't give enough PEEP. Right? It's bilateral tracheal and bilateral bronchial malacia. The baby 4, on the other hand, this really striking feature is that when we did his CT, in the inspiration phase, you can see on the top, the lung is wide open. However, when we turn off the PEEP, and during expiration, this kid lung completely collapsed. And you can see on the right side is the 3D reconstruction of his lung volume. And his lung volume almost is 10 times difference during inspiration and expiration. So this baby needed really high PEEP to open up the lung. Baby 3 really needed the high PEEP to open up his airway. So they both require the same treatment, but their underlying pathology is actually very different. So I hope I have shown you through these cases that you understand the lung disease in these BPD babies actually are different. So if these lung diseases are different, why would we want to put them on the same kind of ventilation? That is my question to you. A lot of people asked, when can I put this baby on BPD ventilation? So if you want to think about how do I ventilate these kids, I think I want to ask 2 more questions. One is, what do they have in common? All these BPD kids, what do they have in common? And also, when you ask when I can flip these babies to BPD settings, why do you think they're different from early RDS babies? Now, like I already said, over the course they stay in our NICU, their lung disease evolved from early RDS to established BPD. And their lung growth also evolves over the course of their NICU stay from the immature lung through growth and injury, and end up when they have established BPD, they end up with delayed alveoli growth and abnormal injury repair. When we talk about RDS lung, we talk about more like this, right? So hazy bilaterally, air bronchograms, right? But we call them one compartment model because we think they're uniformed lung disease. And throughout the lung field, they have similar lung mechanics. And when we really look into the pulmonary mechanics of the RDS lung, because of they have RDS, their lung compliance is really low, and therefore their elastance is very high because it's 1 divided by compliance. And then their airway resistance is either normal or slightly high. So when you think about these kids with very low compliance and normal airway resistance, their time constant is pretty short. So what does this translate clinically? It means that these babies have very stiff alveoli that are difficult to inflate, but very easy to collapse. And they have, therefore, with the short time constants, very short inspiration time is sufficient to fill those alveoli, and they also empty quickly. So that's why when we talk about RDS ventilation, we talk about lung protective ventilation a lot of times so that we try to minimize lung injury we can bring to them. And we use a relatively lower tidal volume, 4 to 6 per kilo. And because of their time constants short, we use relatively faster rate and gave them short I time. And you just need adequate PEEP. Usually it's not that high. Anywhere from 5 to 8 centimeter water would be sufficient to open those lungs. But over the time from RDS to establish the BPD, these babies' lungs undergo a changing pathophysiology, and their pulmonary mechanics changes over time. And what do they, by the time they have BPD, what are some common lung mechanic features? These babies, over the course of several months, they receive positive pressure airway, positive pressure ventilation, those positive pressure extending their airway, and they also have alveoli simplification. And with that, both their alveolar dead space or their dead space in the airway increases. So overall, the dead space in the BPD kids increase. And some of these babies have lung injury that destroy their elasticity in areas, or some other areas may have significant atelectasis. And with that, you may have a compliance very different. In the area that you have lost elasticity, the compliance is actually pretty good. But on the atelectic lungs, the compliance is very low. On the other hand, these kids often have airway epithelial injury and alveolar malacia. And with that, the airway resistance can increase significantly. Some of these babies also end up really fixed obstruction of the airway. And in those areas, the airway resistance really, really increase. So I hope I have shown to you that BPD is a problem that evolves all the time. So it's a continuous problem. It's not like you flip at 36 weeks or you flip at 36 weeks from RDS to BPD. So I really don't think you have a magical time to really switch from an RDS ventilation to BPD ventilation. To me, even if it's an RDS kid, the baby may have very uneven lung ventilation, then your regular RDS setting may not work for those kids. So really, I think you need to watch your baby and really determine what is the lung mechanics at that time and try to really support the baby with appropriate vent settings. Okay, so since the lung disease in BPD babies are different, I don't think there's a one set for all BPD settings. So I actually, at CHOP, I don't let my fellows say, I put this baby on BPD settings. Unfortunately, no matter how many times I say that, people still tell me, oh, I put the baby on BPD settings. What is the BPD setting? I don't think there is a one size fit for all BPD settings. I think what we need to do is choose your ventilation strategy based on your baby's pathophysiology and also lung mechanics. Okay, it is easy to say that, but it's actually not that easy to figure out really what is my baby, this individual baby in front of you, what is really the pathology and the lung mechanics. That takes some time and some experience. Here are some my suggestions. I would say when I get a baby transferred to either CHOP or Guangzhou with severe BPD, the first step I would need to do is really determine is this baby has homogeneous lung disease or heterogeneous lung disease. How you can decide that? Of course, we can do chest x-ray. You can do a CT scan, although we usually don't go to a CT scan right away because that comes with radiation. And a lot of times I can determine without it. And then a lot of our units now use lung ultrasound. So POCUS can really help you at the bedside. And the other hot topics this time at our BPD conference is EIT, electronic impedance tomography. And that can actually give you a visual and also numbers in terms of lung ventilation. And you can see in this picture, there are two babies with different kind of lung disease, right? So one is more homogeneous, one is very heterogeneous with some areas of complete collapse. And there's a one area on the left lower, it's a big cyst, right? When a baby has more homogeneous lung disease, that lung is more similar to an RDS lung. And therefore, when you ventilate this kid, that strategy is probably more closer to the RDS strategy. However, I talked about the BPD kids have increased dead space and also their compliance and resistance changes. So a lot of time, even they have more homogeneous lung disease, they may still require a larger tidal volume, a slightly longer I time, and to really match those changes. But when we have a baby with very severe lung disease, a lot of times it is heterogeneous disease. And we simplify that into a two-compartment model. In reality, these kids have a lot of compartment in their lungs, but we just make it simple, talk about fast unit and slow unit. The fast unit are those units are relatively normal. Their compliance and resistance features are relatively normal, and their time constants, therefore, in those areas are relatively short. Unfortunately, for a baby with very severe BPD, those areas are not much, right? The majority of the areas may be the slow units that you can see either you have loss of elasticity, and with that, your compliance is really good, and time constants will be longer because of that. On top of that, there also can be airway narrowing, either from Malaysia or fixed narrowing. And with that, your airway resistance dramatically increase. And with a high airway resistance and high compliance, that area would have very long time constant. What does that mean? It means air needs more time to go in and really needs even longer time to come out. And if you don't give enough time in or out, you will end up with a problem. And here is a picture. This is a BPD kid from China. And you can see on the left lower, the lung is collapsed. And with that area, we would consider that right to left shunting, intrapulmonary shunting, because you have not enough ventilation, but you have enough of the perfusion. On the right upper, the VQ match is a little bit better, but still decreased. On the left upper, it's better, but by the time it gets to left lower, those areas hyperinflated, the dead space is increased. And with that, your perfusion may be decreased, and therefore your VQ match is not normal either. So what are the problems that we would face if you still use an RDS ventilation strategy for a BPD with a heterogeneous lung disease? Right? The RDS ventilation strategy, I said, fast rate, short I time, small tidal volume. With that, often it's unable to ensure ventilation in those areas with long time constants. Right? If you see it in this chest X-ray, the two areas on the left lower and right lower, it's hyperinflated. And this lung is not, there are areas that are more collapsed. So this lung is very heterogeneous. And with that, you would have more worsening VQ mismatch. And the baby over time will show you air hunger and air trapping. And those areas in the right lower and left lower may become bigger. What about high frequency ventilation? We often have BPD kids that have CO2 retention to 70s, 80s, and people put these babies on high frequency. When you first put these babies on high frequency ventilation, oftentimes the CO2 will come down. But if you leave these babies on this kind of settings, problem would come. Because most of the time, because of the short E time and also active exhalation during high frequency oscillation, it can create small airway choke points. And over time, it creates more air trapping. And the baby often gets more sedation needs. And also, we usually don't let the parents to hold the baby. And over time, you can have really dramatic air trapping. And here is a baby from China. You can see this already have air trapping, especially on the right. This is probably from early PIE changes. And then over time, this baby's CO2 retention become very serious. And then the baby was put on the high frequency. The CO2 came down initially, but this is what the baby's lung become. Okay, eventually this lung popped and had a pneumo. So actually, this is helpful to the baby. The baby is trying to help himself, right? So then a chest tube would need to be placed. What about the other conventional modes? I here listed some common modes. A lot of times we say we don't use IME anymore because we only use synchronized modes, right? However, I've seen a lot of units don't use their flow sensor right, or they don't use flow sensor. That become IME, even you choose an SME mode. But some unit also just use SMB without pressure support. Or a lot of unit likes to use AC mode, especially early on. And I use AC mode early on sometimes, okay? Or PSV mode. Each of these modes has their own features and pros and cons. But when you talk about taking care of BPD with very heterogeneous lung disease with areas that have very long constant, none of these modes can really address that two-compartment model very well. Let's talk about AC mode, for example. When you have a baby with more homogeneous lung disease, you can use that, okay? Because once you trigger it, I call AC mode a patient-triggered controlled ventilation mode, right? Because once the baby triggered the vent, the ventilator takes over using the set tidal volume or pressure you set and the inspiration time you set to deliver the breath. So everything become controlled. So if you have a homogeneous lung disease, that might be okay to use AC mode. But what I have seen people doing is that they think this baby have a BPD, and we talk about longer I time in this kid. So then they put the baby with high back heart rate and also TI that's pretty long. Then I've seen reverse I to E ratio, okay? Then that can cause problems. And some people also do not set their triggering sensitivity right. And then if you cannot trigger well, then don't use AC mode, okay? But when the baby has heterogeneous lung disease, then because every I time is set, all the breaths, as long as you can trigger, the I time is set, then it really cannot address the two-compartment model. And you can see in this example, this AC backup rate was set at 45, but patient was breathing 65 to 70 times per minute, and the inspiration time was set at 0.55. And if you look at the flow time curve, you can see the baby, once the baby finished inspiration, there's a long pause. And then during the expiration phase, though, the baby could not finish. So when you have a baby like this on the vent, the baby finished inspiration, and you tell the baby, hold your breath longer. And then when the baby trying to exhale, it's halfway through or three-quarter way through, and you force the baby to breathe in. Do you think that baby will be comfortable, right? So that kind of baby over time would have air trapping issue and more patient ventilator asynchrony. The baby will be agitated and over time accumulate intrinsic PEEP. And when the intrinsic PEEP is increased, then there will be more patient ventilator asynchrony. So what we consider the best ventilation strategy for heterogeneous lung disease is SMV with pressure support mode. And with this mode, we want to make sure we gave adequate tidal, inspiration time and adequate expiration time. So to do that, you have to set in long enough TI, but you also have to drive the overall ventilation rate low, right? That way you can ensure that you can have adequate expiration. So overall, the baby, I shoot for around 30 times per minute of breathing, not only your set ventilator rate, but also the overall your set rate plus the spontaneous breathing rate that cannot be too fast. Okay. Otherwise, you set a longer I time, and then you won't have enough E time. And then we need to keep the airway open with enough of PEEP. How do you make sure this baby doesn't breathe that fast? Right? We talk about giving long enough I time, give less RR, like set ventilator rate, so that we can guarantee long enough E time. But then you really have to guarantee that minute ventilation. That's why we want to set high enough of tidal volume and give adequate pressure support to support that baby. So overall, that baby's minute ventilation is adequate and the baby doesn't feel the need to breathe that fast. The second step I would recommend people to do is once you determine what type of lung disease you have, the heterogeneous or homogeneous lung disease, and then at the bedside, you try to watch your baby's breathing. If the baby is breathing too fast or has too much work of breathing, you're not supporting this baby enough. So usually you probably have to think about going up on your tidal volume or other support. And the other thing is to look for patient ventilator synchrony. And the vent graphics can tell you a lot of information. And if you figure out this baby and ventilator is not synchronized, there are usually different problems. You can have triggering sensitivity set wrong. You may not have adequate TI or TE, or your PEEP may not be adequate. So really you have to watch this baby. A lot of people just watch from far. Okay, they don't touch baby. They watch from far, they look at the ventilator, and the ventilator looks at giving breath regularly. For example, the graphics on the left, right? The problem here is you're not seeing any spontaneous breath. This is a Draeger vent that the spontaneous breathing breaths are yellow, and you're not seeing any yellow here, okay? And from this curve, you can see the inspiration and expiration both were not enough. What I do, I usually put my hands on the baby's chest and feel when the baby is trying to breathe in, and I watch the vent. And I watch when the vent start giving breath. And you can tell sometimes the baby really actually had a spontaneous breath and the ventilator didn't even sense it. So we call those our missed efforts, okay? And you can see in this baby, if you watch this baby's breathing, and then we also watch the vent, what you can see from the vent graphic here is that you have the first one is a ventilator breath. Right after that, there's another blue, little blue bump. That's actually baby trying to breathe. And also in front of some of the inspiration phase, there is a little bump in front. That means the baby actually already starting to breathe in, but the ventilator didn't sense it till the baby almost finished inspiration. So that's a very unsynchronized breathing patient ventilator asynchrony. And here's another baby that you can see that I said sometimes it's because your triggering sensitivity is not set right or your TI is not set right. So this is a baby I took care of several years ago at CHOP, and I inherited this baby being labeled as crazy. This baby was just at 40 weeks post-menstrual age and was already on high dose of 5 different sedation medications. And when I asked why, people say, oh, this baby is crazy. And what I found out is the baby went to a regular medical team and they said, oh, this baby has BPD. So they put the baby on bronchodilators, not really knowing whether it's even helpful. However, the bronchodilators, every time you gave bronchodilator treatment, it soils the flow sensor. And with that, they figured, oh, let us take the flow sensor out because it creates so much problems. The ventilators we have at CHOP, it's a PEES and neonate dual mode ventilation. So they changed the ventilator to a pediatric block. And from there, the baby needs to trigger from the distal flow sensor. And their trigger sensitivity was set pretty high. The number pretty high, but the sensitivity is low. And also, they think the baby has BPD. Therefore, we need to set BPD settings with long eye time. So they gave a 0.7 second of eye time. And you can see on this graphic here, in some of the breaths, the baby already trying to breathe. The ventilator is not sensing it until the baby is almost finished breathing in. And then the baby wants to breathe out, but the ventilator forces a breath in. Okay, so that baby become very, very agitated, and then they keep on throwing sedation medications to this baby. So what I did is I put the proximal flow sensor back, increase the triggering sensitivity, and decrease the eye time from 0.7 to 0.5 seconds. And you can see over just a few minutes, this baby relaxed. And now you can see it synchronized the vent very well. The baby is more comfortable and doesn't breathe that fast anymore. And over the next 2 weeks, I pretty much, my own job for this baby was actually to slowly wean the sedation. Now, some other baby, when they cannot trigger or have very delayed triggering, it may be because of high intrinsic PEEP. So intrinsic PEEP basically is a concept that for whatever reason, positive pressure accumulates in the chest. At the end of expiration, the pressure inside the lung does not equilibrate with the outside pressure. And basically you have more positive pressure in the lung. And during a regular spontaneous breath, we need to work harder to overcome that positive pressure to generate a flow, right? So it's the same thing for a vent. The baby has to breathe much harder to generate more negative pressure or overcome that intrinsic PEEP to generate that flow. And then the ventilator can sense the baby's spontaneous breathing, right? So here are two other babies. One on the top is a baby with airway malacia. And you can see from his flow volume curve, there is a pattern of early expiration flow obstruction. So it's a concaved flow obstruction curve during expiration, right? And when you listen to this baby, there are really not much breathing sounds, expiration sound that you can hear. And when we did the flex bronchoscopy, we did PEEP titration. And this baby came on PEEP of 6. And you can see on PEEP of 6, this baby, during inspiration, the airway is wide open. However, during expiration, when you only have a PEEP of 6, both sides of bronchus collapse, and especially the left side, especially the right side. And it collapses as a pinhole. And we increased, during this study, we increased the PEEP over from 6 to 8, all the way to 18. Then we see during inspiration and expiration, this baby's airway finally stays open. But this is with sedation and baby being calm. The second baby was a severe BPD baby, got adenovirus infection, and she started wheezing. And again, you will not hear much of expiration sound, or you can hear a lot of wheezing when you check the baby. And the baby is very responsive to bronchodilators. And this is what I see. By the time I saw this baby, you can see on the top, on the left side, the flow time curve. You can see those little bumps. Those are babies trying to breathe, but the ventilator will not be able to trigger, right? The ventilator doesn't know. And you can see from the pressure volume curve, it's almost like a square shaped. With increasing in the PIP, it doesn't really have much of volume change until you really reach very high pressure, and all of a sudden the volume changes. And from the flow volume curve, you can see towards the end, there is a flow restriction there, right? And that was me on call, so I kind of played with her vent. And by the time I go all the way up till PEEP of 24, and you can see now this baby is triggering the vent, and his loops looks much better. We did end up recruiting this baby into a intrinsic PEEP study, intrinsic PEEP study, and we measured out the baby's intrinsic PEEP, and her intrinsic PEEP was at 24. So this baby, when I increased this baby, started off at the PEEP of 12, and that was the curve on the left on PEEP of 12. And she did not trigger the vent until almost PEEP of 18. And by the time it's PEEP of 24, she can trigger the vent regularly. Okay, so I talked a lot about ventilation. And then when it's time that we are ready to wean, I think the problem here is a lot of people really want to wean the baby in a hurry. Or the parents push you, when can my baby get extubated? When can you wean, right? The problem is premature reduction in respiratory support can be really detrimental to these babies. They can become really with more worker breathing. They may stop growing well. They would have developmental delay. And what's more is that they may have pulmonary hypertension come back or become more severe. So I also like to wean the vent. So my philosophy is I want to use the lowest support, but adequate support to support that baby. So when you talk about weaning, you need to be cautious and stepwise weaning. So I think over the years, what I see is that oxygen requirement is a very good indication of how your baby is doing. We often have the most severe BPD kids, even the trached ones, on 21% oxygen. Okay. But I also see baby transfer to us on non-invasive support with 70, 80% oxygen, sometimes 100%. Those babies are not doing well. So your oxygen requirement should be consistently low, preferably in the 30s or less. If the baby has persistent hypocarbia, of course, you will think about weaning. But what we watch most is the baby is overall doing well. They can tolerate age-appropriate play. They can get up and they can have interactions. And they can have sustained proportional growth. And their pulmonary hypertension is stable or improving. But if you cannot achieve those, like really you feel that baby cannot wean, it's not weanable. When do you decide to give a trach or not? And this is a decision really need to balance risk and benefit, especially what I see in China that we do not have very good long-term support, especially outpatient support for a trach baby, right? So then there are data showing that 20% of the trach, like baby's deaths with a trach kid, about 20% was from trach accident. Okay, so it's not without risk, and it involves a lot of support from the whole family, from like social support and medical support, right? So we really have to weigh the balance, the risk and benefit really, really well. However, in some babies, trach really, turn the baby around. It's not a procedure you want to do when the baby is really sick. So when you have the baby is on 70, 80% oxygen falling apart and you say, oh, let's trach the baby. No, because that surgery can kill that baby. Okay. Now it's really for chronic support. But once you do that, these babies are more free. They have a stable airway, they can get up. And this is a study we have published earlier looking at our trached kid before and after trach. And you can see 4 weeks before the trach and the day of their trach, they basically are very growth restricted. They were all born AGA, but then by the time they needed trach, they all like really have growth restriction. However, after their trach, the weight, especially the length, got much better, and their weight to length ratio more normalized towards 50th percentile. But at the same time, we actually gave these babies much less calorie to support them because they don't waste their calorie to breathe anymore. And what's more important is that we see dramatic difference of what activity they can do, whether they can tolerate physical therapy, occupational therapy, and the type of therapy they can do. Before tracheotomy, a lot of times our therapists actually help to support the baby when the nurse are changing a diaper or changing or doing a suction. They cannot do much. But after a trach, they can really do a lot of training. So I talked a lot about ventilation strategies for BPD. To summarize that, it is a physiological based and commonly agreed upon in the BPD collaborative, but they're not really well-studied approach. And we think these babies with BPD have different lung developmental stages. They have different timing and severity of their lung injury, and they have different ability and status of their lung injury repair. Therefore, babies with severe BPD have different pulmonary pathology and mechanics. And with that, we really don't think there's a set time to flip the baby to BPD ventilation. And there's no single right BPD ventilator strategy to flip to. So I'm sorry if you're coming to this talk hoping to hear from me exactly when I should flip these baby and to what kind of setting. I might have disappointed you. And I think for these BPD babies, when you try to ventilate them, it needs to be supportive, but also trying to be protective. It needs to be individualized ventilator management, looking at their pathophysiology, the lung mechanics, and you also need to know your tools. And you need to take time to observe at the bedside how comfortable this baby is breathing, whether the baby goes along with the ventilator nicely, and what the ventilator graphics can tell you. And that's all I want to share with you today. Thank you very much for listening. And I would love to answer some questions now.
Thank you, Huayan, as usual. Amazing talk. Let's see whether there's anything in the chat group. No chat. Oh my God, you've got a clapping hand. Okay, can I ask you? You have given us some very scary numbers. The PEEP of 24. How that goes against the grain of all our traditional teaching. How do you decide? How do you work out how much PEEP this baby needs?
Yeah, CHOP went through a phase that when we first gaining experience taking care of these kids, we had a few kids with dramatic airway malacia, and they needed really high PEEP to keep their airway open. And that's like 18 to 20, more than 20 of PEEP. And then people start thinking, oh, they just need high PEEP. And everybody, anytime somebody desats, they just go up on the PEEP. And then we see more lymphatic kid. They become puffy. Some even have ascites or pleural effusions because you gave more high PEEP that it's not necessary. Okay, so really when I gave you these numbers of high PEEP, it doesn't mean the BPD kids should automatically go there. I think that for the majority of kids, for when they have BPD, they do need higher PEEP than the early RDS kids, but probably around an 8 to 12 range. Okay, not to that high. But if you truly have a baby with significant airway malacia that you determined, we do a PEEP titration through bronchoscopy. Sometimes our CTA can help us, but not others because we do control ventilation CT. And also I think the lung graphics can tell you a lot. Like physical exam and lung graphics. So you can actually figure out a PEEP that probably can help keep the airway open. The other reason is the intrinsic PEEP I talk about. So sometimes when the baby already end up with very high intrinsic PEEP, you need to sort of match that. The adult literature says to match 75% to 100% of the intrinsic PEEP. But then you need to know how much intrinsic PEEP you have, right? So some of the ventilators can help measure that. You cannot use the VM500 or VM mode. Okay, that because you have a flexible flow, you cannot do that. You have to have a vent using a fixed flow rate, and then you can measure. So the Draeger vent we have at CHOP, we can do it under pediatric mode, or the McQuay vent, you can do it. You can measure that doing expersion breath code. You can measure that. Okay. But that takes some experience. But I think the simpler way is actually watch how your baby is breathing and adjust the vent. And each time when I adjust vent, it takes anywhere from 1 to 2 hours. And then I come back. I leave the baby on the setting. It looks better. I leave the baby for a while, and then I come back. I relook, and it takes more time to adjust. So I think adjusting ventilator is an art at the bedside. It's really not based on the gas.
Okay, so basically no fancy equipment, sitting next to the baby and just watching.
Yeah.
Yeah, okay.
Yeah.
Right.
You can use fancy equipment, but most of the folks do not have those fancy equipment, right? I think EIT, there's a potential you can use to measure stuff, and you can help you determine the PEEP.
But basically, good old-fashioned stand next to the baby.
Yeah, because at one time we had an intrinsic PEEP study. We actually have a homemade machine. We put a esophageal balloon catheter in, and then we measure intrinsic PEEP. What I found is that if I spend enough time at the bedside, and the PEEP I come up with are usually quite close to what they measure out.
Oh, okay.
Okay. So I think that nowadays people don't like to watch babies. Go back to the bedside. That's my advice.
Go back to the basics. Yeah. And I guess Pankaj Patel has said, and asked a question that's very pertinent with the high PEEP. What is the rate of air leaks and air leaks with your high PEEPs?
These babies actually don't get air leaks that easy, because I think their electricity is already destroyed, So they really, a few years ago, we were doing liquid ventilation studies for these BPD kids. And initially, we used the same strategy as the early PPHN kid. It basically will fill the liquid till we see the liquid in the ET tube. And this BPD lung really amazed us. It can hold so much liquid.
So they're quite tenacious and not subject to stopping.
For a baby with really severe BPD to pop with a pneumo, it's actually quite hard.
Right. Okay. All right. So you can see we've got lots of questions there. We'll try to go through them. We'll have an extra 5 to 10 minutes. But for everyone online, we'll hopefully set up a whole series of these talks from the BPD Collaborative so we can come together and share our questions and our knowledge about treating the baby with severe BPD. So very quickly, a very common question from Dave Stewart. Do you use cuff tubes and nasal or oral?
Yeah, so both, okay. We do like to use cuff tubes for a lot of our BPD kids. You're not necessarily always have to inflate the cuff. So when we use a cuff tube, our CHOP RTs will go with a minimum leak technique. So they fill the cup till there's no leak, and then they withdraw some air until there's about 10 to 15% leak. They also have a pressure gauge to measure, but it's not very accurate. So usually we like to have some leak, but not that much. Okay. I like nasal tubes. Unfortunately, most of our top attendings do not know how to put a nasal tube in. So most of the time we do not use that. But when I'm on and I need to change a tube, I often do that. It's more stable. And also if frees the mouth, the baby can suck on a pacifier.
That's true. Yes, that's true. All right. So we'll move on down. Aaron from Melbourne has asked about SIMV VG with PSV in heterogeneous lungs. They've had a experience of babies with highly variable top pressures leading to air hunger with quite large tidal volumes. So Aaron, I hope that's rephrased your question adequately. Unmask yourself if you want to ask it differently.
Yeah, that's what we have observed. Some babies with SIMV pressure support ventilation in the heterogeneous two-compartment lung models with higher I times. What we have seen is if we put these babies onto higher tidal volumes, after some time, because of the variable top pressures, these babies end up with being breath stacking and being tachypneic, sort of air hunger-like picture. So and even that's not that big RDS tidal volumes, but a generous tidal volume somewhere around the lines of say 8 ml per kg. Just wanted to pick your thoughts because we are currently having a baby on almost similar sort of situation.
Yeah, so CHOP use volume guarantee all the time. Our vent code VG. So SMV was PSV and VG. So we have not seen that. I think one of the key thing is you have to liberalize your Pmax. So if you use volume ventilation and you limit your pressure that much, that you're not actually end up not delivering your tidal volume, then it's not enough, right? So you have to watch how much PIP the baby will need and go up. And I'm not kidding. Some of our most severe BPD kids had a PIP limit of 90. So we frequently see 40s, 50s. It's you just have to allow that, and they don't pop pneumos. But over time, when your lung is open, you can see those peak pressure comes down. So when you actually give adequate volume, so a lot of times these babies need a tidal volume around 8 to 10 per kilo, sometimes to 12 per kilo. So 6 to 8, a lot of times it's actually not enough for them.
Wow. Okay.
Yeah.
Goodness. Thank you. So we might focus on the ventilation questions for this session. I know there's some questions about nutrition, questions about our good old friends, steroids, what type of steroids. So we will plan for these lectures later on. But I'm not sure how to interpret your question. I think it's Hong Kong Children's Hospital. Inspiratory hold for a plateau to compare to peak. So maybe Huayan, you want to interpret that question? Yeah.
Yeah. So I'm guessing if you want to see the plateau pressure, you would need to do a volume ventilation strategy with a fixed flow, and you have to give long enough eye time to actually see that plateau pressure. This is a strategy we have used that we actually measure these. We measure the peak pressure, the plateau pressure, calculate the difference, and we know how much tidal volume you gave, how much, what is the flow rate. So we took down all these numbers and we use them to calculate out the dynamic under each PEEP. We calculate out the compliance and resistance. You can do that. I put this in the Goldsmith's textbook in the 6th edition, but people don't like to use what we call PEEP grid. Okay, we basically do it under different PEEP. We go from 6 to 8 to 10, and then we measure these pressures out, and then there's a formula you can use to calculate the compliance and resistance. Okay, and then we find a point of PEEP that your compliance is best and your resistance is not that high. So then we use that as our optimum PEEP at the time. The problem with this is to do this, the baby needs to be really well sedated, if not paralyzed. And it doesn't represent their daily life. That's one thing. And also do this, each PEEP grid, I used to do that. It takes 2 to 3 hours and it changes over time. So people don't like to use it anymore. And I had to take it out from the 7th edition of the book. And we're working on the new one that is not going to be there. But I know what you're talking about, and you can use that to determine. If you guys want to know more, I can tell you more. Just contact me. I can tell you how we do the PEEP grid.
I'll put your contact details on the chat pane if that's okay. Yeah.
Sure.
Yeah, lovely. All right. So one last question from Vinny and Gayatri. What do you think of the JET for managing heterogeneous BPD?
Yeah, so unfortunately, there's no JET in China. I have tried JET for some of my babies. Actually, there was one baby which just left on JET for 1 month. Okay. If you do JET for BPD compared to the oscillator, there's advantages because you can adjust your I/E ratio. What we usually do is try to shoot for 1 to 10, 1 to 12 I/E ratio. Okay, so we decrease the JET rate to like 260. Okay, so it's pretty low JET rate. The problem with JET is that a lot of our babies needs really high pressure. It cannot deliver, especially the PEEP. It doesn't. I think there's a limit of PIP of 50. I think. To do with the JET, but it just usually cannot deliver for your very severe BPD kids. It's not enough. So maybe a little bit early case. I think it might be okay.
Early case or late case? Early.
Not the most severe case. So like those evolving into BPD, not quite severe yet. You might be able to do JET for a while. Yeah.
Okay. I put Huayan's email on the chat group. So thank you, Huayan. I get a lot of emails.
We took out the email. So it's zhang@chop.edu.
Oh, is it? Okay. So
either one. I can still receive email from that.
All right, cool. All right, everyone, we could talk for the next 3 years on BPD. It's 10 past the hour. So I want to thank Huayan again. Amazing talk as usual. Remember, we have the BPD Collaborative. We'll be arranging future sessions on other adjunctive therapies for BPD, steroids, nutrition. Please tell us if you want to hear about anything in particular and contact us if you're interested in the BPD Collaborative. So thank you very much, Huayan.